Hi, I'm Rebecca Marshall here with Dr. Richard Rosenfield from Pearl Women's Center, and today we're talking about abnormal uterine bleeding. And I want to thank you again for joining us today.
Hey, thank you for inviting me.
How would you describe abnormal bleeding?
Well, abnormal uterine bleeding, which is referring to an abnormal period, or menstrual cycle, typically is defined as either extremely heavy flow or erratic flow. So either it's unpredictable, and typically the stuff that we get worried about would be when the period is happening for too many days as opposed to too few, although that's something to be concerned about as well. Or if it's extremely heavy, so to the point where women, and this is sort of interesting that in the OBGYN textbooks they quantify it by volume, but the reality of someone measuring the amount of bleeding they're having is pretty rare. So we typically talk to our patients about how many pads are you going through or Tampax during the day, and usually what we hear is, doctor, I don't go to work because I'm either passing clots or I'm going through a super tampon or an overnight tampon in an hour, something like that. That's abnormal. I think it's important to clarify this because a lot of women are pretty much told just deal with it. This is part of growing up and this is your period, but the reality is it can be very, very different for different women.
Yeah, and in all the years I've been on this earth, I don't exactly sit around and talk about that kind of stuff in detail with even my closest women friends. So you really do need to quantify it, don't you?
And I absolutely, and a lot of women don't want to talk about this with their employers, and they're missing work every month because they just don't feel like they can leave the house. So it can be a pretty significant problem, and one that really does need to be addressed and can be fixed if it is something that the patient feels they want to have a fix for.
I feel like I'm going to say a friend of mine, and you're going to think, yeah, sure, it's a friend of yours. But truly, a friend of mine, she was bleeding for like 2 weeks straight. Is that something that they should come see you about?
Absolutely. And then if you think about that, this is a woman who's bleeding half her life if it's 2 weeks every month, and that's not reasonable. So age-wise, if it's a younger patient, we're not quite as concerned. In our patients that are over 35 and especially over age 40, heavy bleeding, we need to rule out things like cancer. So it is important if you're in a certain age group, which we would define as above 35, and once again, really with emphasis above age 40, with a significant change in the menstrual cycle where it's happening more frequently, or things are getting heavier, significantly heavier, it's important to get in to see a board-certified OBGYN physician or a specialist like myself in gynecology surgery.
But what about menopause? Doesn't that kind of make it unclear too? Because supposedly menstrual cycle gets heavy with menopause.
Absolutely, and we love giving patients information that everything is fine.
Yeah.
Okay, we're not going to try to push anybody into anything that they don't want, but at the same time, it's so important to make a diagnosis. The interesting thing is if it is a benign or a non-cancerous problem, but it's a debilitating problem, there are things that can be done as well. And that might be hormone management, which gets into the talk about menopause. So just simply making some shifts in hormones or putting patients on some medication can certainly help. But there's other things that can lead to heavy menstrual flow. And it's important for us to be able to define what those things are so we know that we're not throwing medication at a problem that simply can't be fixed by medication.
Okay, so you rule out cancer, you rule out menopause. What else could it be?
Well, there's a lot of things that it could be. One of the most frequent diagnoses that we make is fibroids. You've probably heard of these before. Fibroids are benign, non-cancerous muscle tumors that are, they like to inhabit the uterus or next to the uterus. And sometimes they can be felt on a physical exam. More often they're diagnosed with some sort of imaging, either an MRI or an ultrasound. And we can do those ultrasounds even in our office and basically let a patient know what the diagnosis is. And then depending on whether the patient has significant symptoms from the fibroids and whether or not they want to preserve fertility or not, we start thinking about options for management.
Are these conditions a pain, just a pain, or painful?
It can be both. So all of these words, they're all Latin root words that we use in medicine, and menorrhagia is a heavy period. Metrorrhagia is an irregular period. Dysmenorrhea is a painful period. And so because of that, we were very specific with the diagnosis. So when we talk about abnormal uterine bleeding, typically we're talking about the actual quality and quantity of bleeding, but of course the pain can come along with it. And if a patient is having pain along with the bleeding, that may also kind of steer us in one direction versus another when we start talking about treatment options.
All right, another scary word in the medical world to a patient is hysterectomy. At what point do you decide to give someone a hysterectomy?
Yeah, and that's a very good point, because hysterectomy has a stigma to it that has been around for a very long time. And lay people's terms of hysterectomy versus in the surgical community can be a bit different. So hysterectomy by definition is removal of the uterus. However, many people make an assumption that when they're going to have a hysterectomy, they're going to have all kinds of hormonal changes. But the reality is we like to leave the ovaries alone unless they're problematic, okay? So hysterectomy is removal of the uterus. This traditionally was only done with a big incision across the skin, you know, like a C-section incision. And because of technology, we've been able to advance and improve our skill set. Hysterectomies can be done vaginally as well, and my specialty, my expertise is doing things laparoscopically, which is a minimally invasive approach for hysterectomy. And we do that through little tiny incisions in the skin, and interestingly enough, when we do these surgeries, our patients go home the same day. So despite the scary part of hearing surgery, it is something that can be done very quickly, and we can get our patients back to work within days. So these women that are missing 2 weeks, or that are bleeding for 2 weeks, or missing a few days of work every month, they can miss those 2 days of work and then never have to miss work again because of this particular problem.
So the recovery time might be what, a heating pad on the couch or something? I mean, how is the recovery?
It's pretty amazing. Our patients that come in on a Tuesday or Wednesday for surgery, most of them are back to work the following Monday. So we're looking at maybe 4 or 5 days. Now, they do have some fatigue afterward, but the bounce back is pretty darn quick. Reiterating once again that that's for patients that require surgery. There are many patients that do not require surgery that we can manage with either hormones or perhaps even a hormone-secreting IUD, which is a device that can go inside the uterine cavity and perhaps improve bleeding that way. But once again, we have to go through the careful history, then we do our physical exam, perhaps get some labs and maybe some imaging, figure out what we think the diagnosis is. Once we have that diagnosis, we have a very candid discussion with our patients about what the options for management are. And those options are laid out for the patients. And for those that are, looking for a definitive result, they want to do one thing, maybe the hysterectomy is the way to go. For patients that say, surgery's scary, I don't want to do that, can we try something else first? Of course we can, as long as we rule out the bad stuff. Once we have a diagnosis of precancer or cancer, we need to have a pretty serious conversation about what the health implications might be in the future if we don't go to the operating room.
Okay, so you have no pain and you don't have the bad stuff, as you say, the real extremes. You just have the heavy bleeding. That is really something that you want to stay home because you have. Are you saying that you can put an IUD up there to help control that? Is that a case where you could?
That is one case where that can work. Some patients don't like the idea of having hormones put in their body. So other patients want hormones, so we have to figure that one out. There's a procedure called endometrial ablation, where we try to literally burn the lining of the uterus away so there's no more periods. The problem with that is it doesn't treat pain. And the other issue with that, it's a nice procedure because it's an outpatient procedure. And when compared to the hysterectomy of days gone by, it's a great option. But at the Pearl, where I do my work, we kind of are looking at doing the hysterectomy versus some of these other things in the same venue. So a lot of my patients are going to kind of opt for that definitive treatment if it makes sense for them. With the big fibroids and in that type of situation, surgery really is the only viable option, but we always welcome our patients to go seek alternative care. They can go see the homeopaths and the naturopaths and the acupuncturists and all these other things that, especially in Portland, we embrace. And then if those aren't working, they know where to find us. And they come back and we work on trying to find them a good solution.
Is this a common problem? If I come to see you, am I unique in that, or is it common?
It's a very common problem. As a matter of fact, 1 in 4 women in the U.S. has a hysterectomy by age 60. 600,000 hysterectomies are performed annually in the U.S. alone. This is a very, very big thing. It's actually the second most common operation performed on women in the U.S., second to a cesarean delivery, at the time of having child. So this is a big deal, and it affects a lot of women. And unfortunately, the majority of women out there do not know what their options are because they don't talk about this at work. They may be getting on the web, but as we know, you get inundated when you get on the internet, and everybody's an expert and can post their opinions. So we were talking about getting on, Wikipedia earlier, and this is
I'm
just
a doctor on Wikipedia.
Exactly.
I'll tell you what
Everybody's
you need to know.
a specialist. So what we're really trying to do, one of our biggest motivators in my practice, is trying to educate patients and women at large about what their options are and whether or not they see us. We just want them to know, listen, there are options that might be less invasive and might be highly effective at treating your problem where you don't need to deal with this anymore.
I want to know what a patient has said to you after you've treated them, like just that one patient that really it stood out, what they said to you.
You know, what'll happen, especially when we get patients from out of town and they go back to work, and they say that they had a hysterectomy, and then their boss says, no, there's no way you had a hysterectomy because I had a hysterectomy and I was out for 6 weeks. And they get into an argument about it. So most of the patients are really, they're just very, very happy that this is, one of the great things when you're a physician and a surgeon is when you can actually fix a problem and you know with absolute certainty that you're going to fix that problem, and you can tell somebody, look, this was your last period that you're ever going to have, and you know, we were thinking that maybe we should advertise in the tampon aisle in the grocery store, you know, are you tired of shopping down this aisle? Maybe you should come see us.
Yeah.
So we just have a lot of patients that are very pleased that they've been able to have a relatively painless experience with kind of a nice ambiance of being in an outpatient center. It's a good thing for them.
And I'm hearing the next angle, you get the hysterectomy and then you take a 4-week vacation after because your boss thinks you're going to be gone for 6 weeks.
That's true.
This is genius. I like it. Always good to talk to you. Thank you,
Thank you so
Rosenfield.
much.
We've been talking about abnormal uterine bleeding with Dr. Richard Rosenfield from Pearl Women's Center.